Yes.
So welcome to final pitch session. I think you're all excited, and I'm excited to see all of your ideas. And before doing so, I would like to thank our sponsors once again, because without their support, this wouldn't be possible. So in track F, we focused on social justice and policy. Let me give you a little bit more overview about the track. Overt and hidden discriminatory procedures, practices, and policies permeate healthcare institutions, perpetuating the healthcare disparities of health outcomes. Dismantling racist and discriminatory policies requires concerted advocacy efforts from all key players in healthcare, especially from patients and providers. So in this track, we tried to answer the following questions. How can we connect healthcare administrators to underserved minorities for patient-centric policymaking? How can we guarantee social justice in healthcare practice? How can we help form anti-racist allies to take a stand when they witness racism in healthcare institutions? In what ways can we create more awareness of the impacts of racism in healthcare? So today, we are humbled by three amazing judges. Lionel, he's an associate director at the DC Mayor Office of African American Affairs. Edgar, he's a managing partner at Harrell Capital Partners. And Dominic Brewer, talent acquisition leader for the US and global commercial business units at Takeda. So as we all know, on Friday, you pitched your problems and then you formed teams. On Saturday, you hacked and you tried to understand the problem and you received feedback from our mentors and you iterated this process. And we are at the final stage. Today, you'll be presenting. So let me remind you the judging criteria. There are 4 pillars. One is impact, the other one is innovation, third one is implementation, and the judges will also focus on your presentation. For the impact, the judges will assess if your solution is solving an ongoing or anticipated problem. For innovation, the judges will evaluate if your idea is novel and innovative. For the implementation, the judges will test the viability and they will consider if this could be implemented in real world. And for the presentation, we expect you to finish your presentation in 3 minutes. And during your presentation, we would like you to answer what problem you're tackling, what solution you're bringing onto the table, and how you're going to implement that solution. So the presentations will be are recorded. Sorry about that. And you will only have 3 minutes to pitch, and there's a hard cutoff. And you will have 2 minutes of Q&A with the judges. The order is random, and we will tell you who is up next, and you will have time to prepare. If you're presenting, if you're the next team, please raise your hands. And when it is your turn to present, you will tell us next, and then we will start the timer, and we will unmute you as well. I think my team support will let you know if of the remaining time, and if there's one, we will give you a 1-minute warning, and that'll be 3 winners per track. This is a typo. There'll be 3 winners per track. Okay, so in terms of raising hands, you'll be able to raise your hands using raise hand functionality of Zoom. I will unmute you, or you can try to unmute yourself. You will present for 3 minutes, and then there will be a 2-minute Q&A. Okay. So first team, ILS, please raise your hands so that I can add you.
Hi, testing.
Yes, Sanyukta, you're the presenter, I guess.
It's me and Mega.
Okay. Mega can unmute as well.
Hi, sorry.
Okay, perfect. So judges, are you ready? Are your your judging forms available right now?
Yes, for team F095.
Perfect. So whenever you're ready, I will start the slides.
All right. Okay. All right. Meet Gabby. Gabby is a 36-year-old mother presenting to the emergency department with an unexplained abdominal pain. The doctor has concluded that the pain is due to stress, as Gabby is working full-time while also supporting her 2 children. She feels powerless in advocating to her physician that her pain is not due to stress. The next 2 weeks, she is admitted to the hospital again for a growing ovarian cyst. Gabby's story is especially common in minority communities where numerous studies show that they feel disempowered in their health.
The problem is not necessarily doctors not listening to patients. It's also patients feeling that doctors don't understand the communities and lifestyles that patients come from. Next slide. Studies show that simply having a doctor that shares your cultural and racial background can increase patient satisfaction. However, in emergency situations, you cannot always choose your doctor. Racial and ethnic minorities have built an understandable mistrust of the medical system due to years of continual systemic oppression. We believe patients have the right to feel heard and also empowered during their visits. Next slide. Enter virtual patient advocates. Patient advocates would be individuals with an understanding of the medical care system without direct linkage to the medical care team, whose sole role would not be to provide advice, but to help patients break down medical topics, provide emotional support, and most importantly, ask if the patients have any concerns with their care. Having individuals that are outside of the medical care team can give patients an ability to talk to someone who they view as unbiased in their care during their visit. Our system capitalizes widely used technologies available in hospitals, such as iPads and Zoom, and can also be accessed by the patient's phone. Remote systems work best to ensure that patients can turn on and off their advocates at any time. Patient advocates who are specifically from communities of color can help bridge the gap between providers and patients if there exists one.
So what makes this program different from what exists? Well, when a patient comes in with an emergency, it's not always possible for them to have family members or other support immediately with them, increasing the need for an unbiased support system. An emergency situation can be one that is already causing panic and worry, and having a dedicated advocate could help alleviate these concerns. Next slide. We envision a pilot volunteer program that would include medical students or retired healthcare professionals, primarily people of color, to be part of a cohort implementing a virtual patient advocacy program. This program could serve as an elective course for medical students to be completed in their 3rd or 4th year and would also assist in increasing cultural humility education. Next slide. There are many benefits to multiple parties involved. Patients would have more reliable support and better care. Hospitals could have increased revenue due to increased patient satisfaction, and insurance companies could also save money through fewer hospital readmission rates. If Gabby had the support of a system like this, she may have avoided her readmission to the hospital altogether. We believe that every patient deserves to feel comfortable and deserves to feel heard, and this is not something that can be done by physicians alone, something that takes a team effort to solve. But by taking this small step, we believe we're going in the right direction of increasing patient comfort in the healthcare system, especially for minority communities.
Your time is up.
Thank you. We can go to the Q&A next. Yeah.
Nice. So we can have questions from our judges.
Hi, team. Thank you so much for presenting. I guess I'll ask the first question. It looks like this will depend on a supply of people that fall into a minority group, either on the medical student side or on the retiree side. How would we address challenges with the lack of supply potentially available in those respective communities?
Yeah, that's a great question. I think this program, we would ideally want people of that background, but it obviously doesn't have to be limited to that. I feel that this program could be applied to other individuals as well. It just, they would have to go through a process of making sure that that individual is ready to be working with these patients.
Additionally, another aspect that we were considering was involving pre-medical students as well from communities of color. This specifically would help increase the clinical opportunities that they have as well, which could also lead to later more people of color within the medical system as well.
Any more questions from our judges?
Edgar, you're muted.
Edgar, you're muted. Edgar, we cannot hear you. Lionel, do you have questions?
Actually, one of my questions was just I asked. I think that variable of the support system, and I think the participation of the healthcare companies. It's a great idea. Something that they would kind of be like virtual navigators, if you will, and I think it's something that could exist in this COVID environment and beyond. I really would love to see this actually implemented, but I think with two of my burning questions right now.
Thanks, Lionel. So
Thank you.
2-minute Q&A is done, so we can move on to the next speaker.
Thank you so much.
Thank you.
Perfect. So next up, Team F30, Team Humanidades. Are you all here? You can unmute yourselves.
Yeah, we're here.
Yes, we're here.
Yeah, we're here.
Good. So whenever you're ready, maybe I should check with the judges. Were you able to fill out the Google Forms for the previous team?
Actually almost done with that.
Okay.
Yeah, still leaving feedback and comment.
Okay.
Are we supposed to fill out a form for the first one?
Yes, you need to fill out a form for every single team.
How do I get the form?
Okay, that's a good question. Allah, can you help with Ed about the form? Can one of the track supports help Ed?
No, I'm sorry. I just don't, there's a form. I don't know. I don't see how I get it on my screen. But anyway.
Yes, I'll send it to him.
Thank you. Thank you. Thank you. So next up, Team F30, Team Humanidades. So whenever you're ready, you can start, you can tell next, and then I will start the presentation and the timer.
Okay.
Okay, time starts.
Hi, my name is Anola Lafresher, and my family moved to the United States when I was 12. But not long after moving here, I developed respiratory issues. And it took 12 years before finding clinicians who not only looked like me, but also made me feel like they really cared about my overall health, and because I felt like they listened and understood me as Anola and not a potential statistic. Next slide, please. But it's not just me. Studies show that patients are more trusting and open with clinicians when they look like them. Health systems don't have the right clinicians to give patients the care they need. This is true for racial diversity and also other forms of representation. Even though health systems are aware of this, they don't have the right tools for finding diverse candidates that can better serve patients' needs. This is why we need to be well connected. Next slide, please. Well Connected is a tool for health system administrators. It is a cloud-based system that assesses the demographics and health needs that health needs of your patient population. It also identifies gaps in your clinical pool and matches you to the best clinicians for your patients. Well Connected draws on multiple data sources, both internal and external, to assess who your patients are and what care they need. Then we compare this to your clinical workforce to identify diversity gaps. And finally, we recommend which clinicians you need based on both diverse identities and clinical skills. We connect you to job platforms to bring these talents directly to you. Next slide, please. Oh, yeah. There are job searching tools on the market and tools that elevate diverse candidates, but none mediate a three-way relationship that focuses on patient needs. Our dynamic solution assesses community health needs, assesses the diversity gap, and ties into established job search sites to assess candidates' profiles and bring diverse talent recommendations to them. By doing this, we improve health outcomes for our patient populations. Next slide, please. Thank you.
Perfect. So we have 2.5 minutes for the Q&A.
Can I have a question?
Edgar, go ahead, please.
My understanding is that what you're proposing is that the problem is that you have to have people who are well connected, understand the market, which we will be part of what you present. And this is what differentiates you from what's now being offered. Is that correct?
Yes, that is correct.
Thank you.
Can you advise, it looks like, is this a supply to match? Is it a mixture of a job kind of alignment or service? How are you aligning, assessing, and meeting those needs? Because I saw like Barry Godboss and a couple of other organizations as well. And I'm just curious, how will that work together?
Right, so that's a great question. We envision this as a plugin that would link to existing job funnels, like, for example, LinkedIn or ZipRecruiter. The value that we're adding is that we are using patient needs as the source of criteria for those job searches. So it's not just a two-way relationship between the employer and the employee, but it's a three-way relationship that defines employment criteria for medical workforce based on the actual needs and also racial and ethnic and other characteristics of the patient population.
And so there would need to be some type of subscription or buy-in to leverage your service for those organizations to then benefit from it. Is that?
Yes,
Right.
that's correct.
Yeah, we were sort of envisioning like, this would be a culture tool as well. So we would need sort of buy-in from organizations, maybe partner with one organization that sort of wanted to play around in the experiment with us and really go all in on this notion of sort of data-driven.
Thanks, Peter. So I think the time is up for the Q&A. So we will go to Team F12, mental health doulas. Before transitioning into this team, I'm going to ask the judges if they were able to complete their forms for the previous team.
I am just leaving additional feedback.
Perfect, thank you.
I haven't filled out forms because I haven't got the form, but anyway, I've rated them and I have it on paper.
Okay, perfect. Thanks, Edgar. We can discuss this as well. So next up,
I don't see the raise your hand function.
you can unmute yourself. That's fine.
Okay.
Okay, is everybody here from Team F012, mental health doulas?
We're here.
Okay, perfect.
Yes.
So your time starts whenever you tell me next.
Next. This is our team, Team F. Next. So we all grieve tragedies such as that of Daniel Prude, whose mental health crisis was treated as a criminal act. He died soon after his encounter with law enforcement. Next. The problem is untreated mental illness is treated like a pipeline, and it's the pipeline into the criminal justice system where low-income Black and Brown people with mental health challenges routinely fall out of treatment and into crisis. Untreated mentally ill people have much higher rates of police interaction, and the consequence is violent, traumatic responses to people experiencing a mental health crisis. Next. What if people in crisis were not treated as criminals? Next. Meet Officer Daniel Ortiz. He is an officer with the New York Police Department. We imagine that he has seen many crises such as this and has only had 2 hours of training in his 1 year on the force in approaching people in crisis. But he's seen Jovan 3 times in the last few months and has arrested him each time. But he's recently heard about the mental health doula program and contacted them about Jovan. Next. Jovan is a man who is 19. He's got parents who are working full-time, both of them, and he's out of school. He has encountered several stressful situations recently and has been suicidal in the past. And like we mentioned, he's been arrested 3 times since May. He has general anxiety disorder. Next. And this is Marcos. He works for the mental health doula program to support the mental health community of members. And he serves people like Jovan to help them navigate the mental health paradigm to prevent crises and support wellness. Next. So this story was different. Jovan says he hasn't lost it since Marcos called him and he got the help he needed. Officer Ortiz said, I hated taking care of calls from people in crisis. All I could do was arrest them for their behaviors. This is better. Marco said, this is such meaningful work. I know guys like Jovan will get into crisis level because we're here to help them get the support they need next.
So what's important about this option is that creating a mental health doula certification program with a lead-in will lead into a healthcare offering, payer network, cost reimbursable offering. Why that's next. Why that becomes a key game changer is that through offering the service within the payer network's cost reimbursable model allows for greater consistency and continuity of service. We see today that over 2 million times a year, people with mental illnesses are jailed, and we know that the heightened interaction with law enforcement leads to greater mental health issues and crises. Next, untreated mental illness costs the nation billions annually, upwards of greater than $300 billion a year.
Your time is up. So we'll move on to Q&A with judges. Lionel.
I think well, actually, yes. Could you
There's feedback.
Lionel, you can keep talking.
Oh, I was saying, could you just follow up on the point you were making?
The point about the key with having this program and the cost reimbursable model is that we know that there are similar programs that touch aspects of the doula program. However, there's nothing that has that continuity of a long-term peer support to help a person with mental health challenges navigate the system and act as their advocate. And by using the payer network as the funding source, it allows for greater continuity. We know that a lot of cities have some types of programs that are more crisis intervention focused, but without having continuous support, it often leaves those individuals without care. And we know that we've done this before successfully with maternal health, with the implementation of maternal health doulas within Medicaid Part A and B.
Dominic, you had a question?
I have a question about implementation. I think it's a good idea, and it would fill a huge need that's out there. But there's so many intersectionalities here. How can you scale this on a larger forum?
Yeah, no, definitely. And I go back to the point of, we're going to use the prototype of, I was key to the work done to allow mental health care doulas into the Medicaid A and B program. It was a 4-year horizon, 4 to 5 year window in doing so. But I think the scalability comes by focusing on pushing the political will towards adding that service in the payer network model, which then allows for greater universality of the service offering to the public.
Thanks a lot. I think now we can, Edgar, I think we should move on because of time constraints.
Yeah. And I don't know exactly what you are offering. You're offering a focus that something is neglected now, and that's the mental health thing. But what exactly are you doing as a team other than identifying the problem and advocating change?
Can you reply in 15 seconds?
A certification program to start the process of the conversation of changing the policy on Medicaid. And as a policy SME, using my lobbyist skills to change the law.
Thank you.
Perfect. So the next team is Syra. Are Syra members here? You can unmute yourself.
Yes, hello.
We are here and we are ready to go.
Hello. So whenever you say start, I will start the timer and the slides.
We start. Hello, everyone. Good afternoon. We are Team Syra, and we are excited to introduce our solution, SRI, with the aim of eliminating racism in research and publications. Next. The problem is scientific racism is based on the false belief that race is biological instead of a social construct. And it is deeply entrenched in research studies as well as in publications. Scientific racism is a critical vehicle of structural racism and a key driver of health disparities as it informs medical education, clinical practice, and public health. If we are to truly eliminate health disparities, we need a tool to screen for scientific racism in research studies and submissions for publications. Next. So we introduce our solution, SRI, the Scientific Racism Index, which is an anti-racism screening tool for research publications to be used by researchers, universities, journals, and funders. Next. For example, this is a tool, an article that was retracted from a major high impact journal, international journal this year, because it was incredibly racist. It truly was a concern. Next. And so our tool, the SRI, is created as a artificial intelligence model that will be trained by diverse stakeholders and will deliver a score on a scale of 1 to 100, with 100 being most racist and 1 being least racist. There's precedence for such a tool as found in the entertainment industry, exemplified by the Gina Davis inclusion quotient. There's also another tool in the human resource industry. However, there is none in the scientific and medical research space, which truly provides an area for us to grow. Next.
Implementation. Phase 1 design consists of, there we go, building a diverse multidisciplinary team that includes credible and trusted partners in anti-racism. Phase 2 will pilot with research institutions and offer manual review and scoring to ensure SRI is calibrated correctly. In Phase 3, we will offer subscription packages to our consumers. Next. This is our sample pricing and what it will look like for basic, premium, and deluxe offerings. And we anticipate subscriptions from health systems, researchers, funders, and journals and publishers, et cetera, and plan to increase capacity over time. To promote transparency and accountability outside of our subscription model, we will have a website for the general public to display all evaluated articles by the SRI.
So here you can see a model of the website where people will be able to search articles by name, author, and DOI link, and they will pop on a link to the article. But to the side, you can see that the SRI will present them with an index. This is the article that
Your time is up. Okay, I think we can move on to questions from judges.
Yes, I have a question. Do you have a capability within your team to model this thing for AI?
Could you repeat the question again, sir?
You're using AI. Obviously, you're going to search and have a model, some kind of a model which identifies articles that had this problem that you're talking about, racism. It's based on some search of other articles that will or will not based on your profile. That just means you have to access a lot of data banks using an AI model. Do you have people within your group that have that capability?
Within my organization, within IS, and as a part of that, I do have teams that I work closely with that are doing it for my system internally, but not specific to what we've come up with.
But that's your model, though. That's your innovation skill. You're now giving models. You're giving advice on racist article based on a model.
So we'll have to create our foundation from scratch because the data that's available now is biased. But as far as the data miners and for the data scientists that'll need to comb through and help us come up with the algorithms, we'd have to build a special team for that.
Okay, thank you.
So if I understand also, this is something similar to like what we're doing for, job description and language, right? Pulling together a complete database, finding people that can create, to your point, the coding and access all the information, and then publishing for transparency. Is that correct? And this would be a subscription-based model?
That is correct.
Okay. Lionel, do you have anything?
I saw the price points for the subscription. I would just want to know, well, I think once it's developed, you probably be able to figure out the target audience and the size. But I don't know. I like the questions that Edgar asked, and so I'll thank you for the feedback. This is a great proposal. I just think it would need additional implementation.
We have a diverse, and I'll tell you that we have access to through our networks, these current teams, Syra, we have access to diverse multidisciplinary teams with partnership with leaders in anti-racism research that will inform the model. And our end users will be.
Babe, Tegan still needs to move this so I can get my car out.
Okay. I think we need to move on to the next team.
Thank you, guys.
Thank you.
Thanks a lot.
Thank you.
So the next up is EigenDX. Please unmute yourself.
Yes, we're here.
Okay. I will start the slides whenever you're ready.
I'll just start then. Hi, we're EigenDX. Before I tell you about our project, I'd like to first tell you a quick story. Next slide, please. Meet John and Chris. They both like the outdoors and they often hike together. On their last hike, they both got bitten by ticks. For those of you who don't know, ticks are generally harmless, but sometimes carry Lyme disease, and Lyme disease can be caught early and cured before it causes problems. About a week after their hike, both men felt a little bit tired and a little off, so they each went to their doctor. Unfortunately, this is where the similarity ends. Lyme disease is diagnosed based on the patient's symptom. One key symptom is a bullseye rash pattern around the site of the tick bite. John's doctor quickly finds this pattern and gives him antibiotics. John looks like the example pictures. Chris is not so lucky. The diagnostic criteria for Lyme disease, as with many other diseases, was made using data from white people. Telltale symptoms that exhibit themselves on lighter skin might not be obvious or might not happen at all on darker skin. Next slide, please. And this isn't just one disease. Often diagnostic criteria that were learned on white people are applied universally with suboptimal results in non-white populations. This costs the healthcare system billions of dollars and can cost minority patients their lives. And the disparity is not closing. As we move to AI-assisted diagnostics, we become much more reliant on training data. And as we know, that training data is biased. Next slide, please. Enter EigenDX. EigenDX is an enterprise platform to improve minority diagnostic outcomes. EigenDX brings together patient-inputted data, healthcare provider education, health records, and privacy-first diagnostic data pool to form equitable diagnostic standards. Chris here can enter his symptoms into the app, including a picture where he knows the tick bit him. When he is eventually diagnosed, we will pull that information from his health record with FHIR. Chris's doctor would have benefited from EigenDX. With EigenDX, he would have had an information overlay on Chris's electronic health record. This would provide additional context, making the doctor aware of how a disease may present differently in different races and ethnicities, and filling in blanks on why symptoms, such as a red bullseye rash, might be missing. The data is all stored on our servers, which integrate privacy and HIPAA compliance to allow those who are building the healthcare solutions of the future access to high quality and equitable data. Using anonymization and techniques such as differential privacy, this data is distributable to companies looking to improve healthcare. The next generation of healthcare apps can have social justice baked in from the data source. Next slide, please. The NIH estimates that approximately $50 billion are spent each year unnecessarily due to healthcare inequity. By targeting and selling to insurers and healthcare providers and reducing their costs, EigenDX can increase equity in the healthcare system while also helping everyone's bottom line. Our initial plan would be to implement a pilot program at hospitals which serve large, diverse regions such as UPMC in Western Pennsylvania, Kaiser Permanente in Northern California, or the VA. We would also like to bring in a smaller system which serves a predominantly minority population as a partner to the larger system in the pilot program, so that we can show the data sharing works and that there are quantifiable gains in healthcare outcomes across both systems and all populations. Next slide, please. Thank you. Any questions?
Okay, we can move on to the Q&A session.
Yes, I do. I'm not sure exactly if I understood what was going on here. It sounds to me like you have people that will provide that their symptoms of what they have, and then you have a model or some kind of data which differentiates a evaluation based on what your model tells you. This is for people of color or people of different ethnic or racial background. And the secret sauce is you're now doing something that differentiates the symptoms and how that would react or how it should be addressed in terms of diagnostics, and that the cost for this being wrongly diagnosed now is 50 million. Is that right?
It's 50 billion.
Excuse me, 50 billion. I apologize.
Almost. So we're not trying to diagnose anyone. That's not our role. I don't trust AI to be that it's not FDA, qualified. But the real goal here is to understand how symptoms present in different people. There are bodies of knowledge that say these aren't necessarily disseminated to each practitioner. When a healthcare practitioner looks up examples for a bullseye rash, they get almost universally what's on that left column that I showed, which is all white skin, pink red rash. Even Google will do this for you. You will rarely find examples on dark or black, brown skin. But being able to present that to the provider by integrating with the EHR system that their hospital already uses, we can sort of keep equity. And then by pulling that data back and anonymizing it, we can allow all these fancy AI diagnostic startups that are springing up to have a data source that we at least understand to be significantly more equitable than what is available today, if not totally equitable, which is a very lofty goal. There's always going to be
I will ask our judges to ask one more question.
Yeah, I just have a really quick question. So basically, Nathan, this is going to be an app that people have access to. You provide or push awareness of it, and you're crowdsourcing symptom information to then better inform providers' diagnosis of the outcome. So there's some type of subscription or supplier data that would filter into those organizations that you mentioned previously.
Nathan,
primarily our customer.
Please answer in 15 seconds.
Primarily our customer is the insurance or healthcare system. They're the ones who actually reap the cost savings for the most part. The end user gets this app as just sort of like an increase your care tracking type app. Okay. But I think to answer your question, we are targeting the large health systems who will be billed annually or monthly.
Perfect. Thanks a lot.
Thank you.
So the next team is the Go-Getters. The Go-Getters, are you here?
We are. I am.
We are. You can unmute yourselves and please let me know when you would like to start.
All right, start. Becoming a BIPOC healthcare provider of choice in today's healthcare system. Next. Disparity in healthcare is an ongoing problem in the healthcare system. African Americans are at higher risk for conditions such as hypertension, diabetes, and stroke compared to white counterparts. They are also more likely to die from these causes. Next. An example of this is the Tuskegee experiment. 600 African American men in rural Alabama were injected with syphilis. Both diagnosis and treatment were withheld, which led to distrust in the healthcare system and dampened healthcare seeking behaviors and healthcare utilization. Next.
The earlier was just one story that exemplifies the long history of BIPOC and intersectional communities not trusting healthcare providers. We seek to solve that through our multifaceted approach, engaging healthcare providers, health partners, and the community. Next. With potential AMA endorsement, we'd like to introduce the Healthcare Provider BIPOC certification, the BIPOC-I, available to all healthcare providers. Patients will be able to search for BIPOC-I certified providers who are trained across meaningful dimensions that matter most to the BIPOC and intersectional communities. And with momentum, we'd like to see global organizations like WHO adopt and endorse the certification as well. Next. Earlier mentioned, there are multiple dimensions of the BIPOC-I, which you can see here. The last three are what really differentiate us from the other certifications. Next. Once BIPOC-I certified, healthcare providers will encourage patients to rate their level of care, keeping in mind patient usability. Next. And by combining the certification and patient ratings, we will see more equitable healthcare through the creation of much needed checks and balances. Next. Our healthcare certification will be the first that checks all the boxes above, providing comprehensive BIPOC and intersectional community healthcare education. Next.
Now that you know a little bit about our program, I would like to show you how our program brings value to key stakeholders. So We identified 3 key stakeholders, clinicians in their respective institutions, the medical device industry, and patients. So by our program will increase the number of patients, and this will help hospitals grow the revenue. And with having more patients in the hospitals, you increase product usage from the medical device industry. So this will help boost their sales as well. And most importantly for patients, they have a better clinical experience, and we build that trust between the community and our healthcare system. Next. So we've talked to you about the value to clinicians, the medical device industry, and patients. So how do we put this information into the hands of our patients seeking care? They can search online for any BIPOC eye certified clinicians. Next. Thank you for your time. Are there any questions? And next.
Perfect. 3 minutes. So we can have questions from Dominique first.
It sounds like this is an opt-in where people actually have to raise their hand to participate, or is there going to be some type of alignment with the sectors that you're partnering with to start, or is required?
It'll be optional at first. We'd like to be able to identify those providers that have interest in being able to further healthcare for the BIPOC and intersectional communities specifically. So we can understand better how they'll be able to utilize that information and what barriers and roadblocks that could come up in case we do decide to get a mandate as part of healthcare. We do want to be able to introduce this as something that is mandated as part of medical school, but not necessarily active practitioners for the first round.
Okay, and if there's a limited response, how would you plan to propose an alternate route to making sure people would participate in something like this?
David, would you speak to this?
So that's where we're really going to talk to the value that the program can bring, not only to the patients, but also to the clinicians, their respective institutions, and any other sponsors or champions that we might have, like the medical device industry. Like this program helps everybody. And that's what we would try to pitch to show them, like, you know, if you choose not to participate, then you're hurting yourself, you know, because of the value that this program can bring.
Thank you.
I wasn't sure who you're certifying.
I beg your pardon?
I wasn't sure, I wasn't understanding, I wasn't sure who was being certified, whether the patient was or whether the person who's dealing with the patient.
Would you like to speak to that?
Yes, it would. We would start out with clinicians. So basically it would be mid-level providers, physicians. Like Cynthia said, we would try to implement it in a like medical school. And then at some point it's going to have different levels of what that looks like, because what a physician needs as far as BIPOC training, a medical assistant's not going to need that same training. So it would be different levels of BIPOC
Bridget,
training
the
depending
time is
on.
up. Thanks a lot. So the next up is the Green DEI group. Can you unmute yourselves? The Green DEI group.
We're here.
We're here.
Perfect. So you can tell me to start whenever you're ready.
Okay. You can start. Welcome to the Black Patients Green Book, a mobile app for quality healthcare presented by the Green Day Group. Next slide. Where can Black patients find culturally competent and effective healthcare? A major hindrance Black people seeking medical care have faced is access to a medical professional who is attentive to the needs of Black patients. Studies show that doctors are less likely to trust a Black patient's assessment of their own illness. The result is a disparity in healthcare outcomes for Black patients. As a Black woman who has been navigating the healthcare system since she was 14, the picture you see on this slide is a face I see a lot. Currently, there is no centralized database or listing where patients of color can search for hospitals and knowledgeable providers who will take their pain seriously. Next slide.
So what is a Green Book? First published in 1936, the Green Book was an annual guidebook for Black motorists. The book contained listings of establishments that were relatively friendly to Black people. Next slide. Our solution is a modern day take on the Green Book. It is a digital Green Book for Black patients in search of equitable healthcare providers and hospitals. The Black Patients Green Book would be a location-based directory application for mobile devices. Next slide. The Green Book would work by allowing patients to be able to download the app onto their mobile device. Only providers certified by trusted DEI programs, such as the Healthcare Provider BIPOC Certification Program created by Team 8, will be included in the app, assuring patients will be matched with quality physicians. We will integrate technology features such as Google Maps to aid patients in locating certified doctors in their area. Next slide.
An app that connects Black patients to empathetic providers will benefit a diverse group of stakeholders across the industry. Next slide. Our app will travel with Black patients, providing them culturally competent care wherever they are. This is a rarity in the market. Initial market phases would include working closely with local orgs trusted by Black patients. Future versions of the app would include verified patient reviews using validated questions from Hausman, which point to the perceived level of racism or discrimination of patient experiences. Intersectionality of gender, race, and sexuality will be components that will allow us to expand the reach of our solution in hopes of addressing social determinants of health which are critically impacted by systemic racism. Next slide. Current apps on the market match Black patients with Black providers. Our app will expand upon that, providing information on diversity, equity, and inclusion certification of individual providers. Next slide. This has been a solution provided to you by the Green Day Group. Thank you.
Perfect. Lionel, we can start with your questions.
Yes, I like this idea, and I know it's contingent upon the Go-Getters diversity and inclusion certification, and I know that you will actually include those that had a certification and also other Black medical practitioners. But tell me this: would you all wait until you had a good pool of folks who were certified, or would you launch this application and move forward? Because I think the selling point is that you have a wide offering of folks that have that certification.
I think our initial moving to the market would require us to think about, to work along organizations that, to basically not reinvent the wheel. So there are organizations such as the Disparities, the Racial Disparity Center in MGH that kind of looks into these kinds of works. So finding out where that information is available and trying to pool it together in initial phases, so at least there's some certified information available for patients until a more robust and stable certification program is created.
This all really depends on how well you evaluate the clinics or the doctors.
We see our app as not the initial source that is doing the evaluation, but that is disseminating that evaluation and making it easily accessible to Black patients.
Well, how do you evaluate the doctors?
That would be the work of a third party that we would work closely with.
I see. Thank you.
Dominique, do you have a question?
Yeah, so what is the actual model? Because the idea is to partner the people up, but how are you pushing this? Is it through subscription service, partnering, evaluation, or advertising with an institution or provider, or what is the intended method of getting this out to the public?
So this would be a free mobile app, and we would work in partner with organizations that currently work with Black patients. So organizations that are trusted by Black patients and using and then disseminating that app out that way.
Thanks, Rebecca.
Black area, how can you get past that? I guess that's the major question, right? Is like people actually that aren't using something like this, how can you advertise for them to start leveraging it to gain trust? I guess maybe that's the better question to ask. Sorry,
I need to move on to the next team
Thank
because
you.
of time constraints. Thanks a lot.
Thank you.
So the next stop, Team F037, hook, line, and the linker. But I think I will give a few minutes, few seconds for our judges to complete their forms.
I'm going to have to fill out all the forms when I get off this line, I think. I don't have any forms yet.
They might have been emailed to you.
I'm sure you sent them, but I don't know how to get them while I'm paying on this line now. I'm going to have to wait till we're finished.
Sure. Team Hook, Line, and Linker, are you ready?
We're ready.
Perfect. You can tell me when to start.
Okay, you can start now. Good afternoon. I'm delighted to be presenting on behalf of our group, Hook, Line, and Linker. Next slide. A retail-based testing plan leaves communities of color behind. That was an actual headline in Chicago earlier this year, where although retail testing through pharmacies was ramped up for COVID-19, largely Black neighborhoods were rendered without accessible testing sites. A similar picture is painted in New York City, where COVID-19 has ravaged largely communities of color, including Black Americans and immigrants. Currently, there's lots of data on social determinants of health available, and there are resources that help communities mitigate the negative impacts of systemic racism. So what if we had a way to link the communities most impacted by disease burden and the services that can actually help them improve outcomes to ensure that resources are being equitably distributed to those who need it the most? Next slide. Connecting communities to care networks is important because often the people impacted by racism are not at the decision-making table when it comes to policies and programs. Community perceptions matter. Community trust matters. Next slide. We propose a visual dashboard that includes geospatial mapping to connect communities to care networks using aggregate data. This dashboard aims to understand the landscape of how social determinants are related to community resources, where health facilities are, what neighborhoods are actually under-resourced, and how can we use organizations and champions who know their communities to better build a resource and sustainable community infrastructure. Our dashboard allows us to tell a story using data so we can actually see inequities where they lie. Having this information can drive advocacy and interventions to the areas that need them the most. Ultimately, this dashboard can be scaled to address other areas such as housing access, food insecurity, and employment opportunities. Next slide. Of COVID-19 between the Community Action Partnership, State Medicaid, and a State Board of Pharmacy, we will incentivize community pharmacies to connect with community groups to identify and address gaps. Our dashboard paves the way for sustainability by demonstrating impacts on preventive care and reduced overutilization of healthcare. It also creates a business case by allowing culturally appropriate messaging and public health detailing efforts to promote the use of preventive care services that reduce overall long-term costs and improve early detection and treatment of disease for better morbidity and mortality. Next slide. This pandemic is relevant now, but investing in our community infrastructures on such a grassroots level will pave the way for a more equitable tomorrow, especially using the amazing talent on our board that includes clinicians, policymakers, public health practitioners, data scientists, and community advocates, as well as civic engagement. Thank you very much, and I'd welcome any questions you have at this time.
Yes, I have a question.
Edgar?
Yeah, it looks to me like what you have is you're developing a network of information about data, which would indicate the inequities in terms of providing for Blacks or minority groups. The payoff is getting people to do something. And you can have wonderful data, but if no one wants to do anything and you can't influence, it's not a very successful project. How good will you be, or how will you go about getting people to use the data you have to implement change?
Excellent. So for first, we want to start out with a use case for COVID-19, since there's been a lot of lack of trust with vaccines. There's been a lot of accessibility issues when it comes to testing sites. So we would love to incentivize for community pharmacies to partner up with community organizations. So somebody who is trusted and entrenched in that community that can help with appropriate messaging, communities that they trust, and can garner more support for advocacy for use of something like COVID testing or COVID vaccines, for example. And then you can expand that over, because once you have the community's trust, that's when you're going to actually get those access points in the healthcare network to start utilizing and sending the message that we're here to actually improve preventive care services, to provide uptake.
Lionel, do you have any questions, or Dominique?
No, I don't have any questions at this time.
I think it's a great presentation. The only question I have is, you mentioned the community organization to help with that trust, which is great. As far as the access, is that built in through the partnership with the community pharmacy? So it's already the model of lower costs, et cetera, for those individuals to get the testing and what have you through that partnership that you're creating?
Yeah, I think what we find is that right now, all these disparate sources of data already exist, but the linkage is just really not there. And by using sort of data visualization and mapping, you can see, for example, where there are clusters of testing sites in certain neighborhoods, and certain neighborhoods may have testing deserts or vaccine deserts. So we want to link those things together so you can make the case and then go and advocate for better resources and policies. So that would actually drive something there. But right now, just saying it or saying that we need this in the community may not be as compelling, but adding all those data and putting it on a map so people can actually look at it, you can make the case that, look, there's a vaccine desert here, or these communities have been disproportionately burdened by X disease, and we'd like to send more advocacy and resources there.
Thanks, Big Beauty. We will move on to the next team.
Thank you.
In a few seconds. So the next team is Health Force. Are you here, Health Force?
Yes.
Yes, I'm here.
Yes, I am here.
Perfect. Let's wait half a minute and then we can start. Health Force, are you ready?
Yes.
Okay. Whenever you tell me to go ahead, I will just start the slides and this timer.
Okay, I'm ready. Empowering BIPOC communities through community-based health education access. Next. Meet Janice, a 29-year-old based in Richmond, Virginia, who has trouble demystifying and finding health information that is relevant to her. She's active in her community and has no time to research resources. She needs quick access. She also has diabetes. While her doctor initially provided her with a 70% chance of remission, this reduced to 25% due to lack of resources available to her. Next. BIPOC are unfairly at a disadvantage when it comes to healthcare literacy due to barriers in access caused by socioeconomic status stemming from colonialism, systemic racism, and bias. Next. Let's implement a program to empower BIPOC individuals at the community level and increase access to literacy and resources by partnering with community orgs. To make this program accessible, we will launch our free app, Health Force. Next. We empower patients and encourage them to engage in their care and health literacy. Our community-centric program aims to reduce structural racism by addressing often overlooked topics at a culturally relevant and responsive level. Next. We would launch a campaign both digitally and physically, and we have assessed the market and find this a viable option. Next. We identified our competitors. Next. In Janice's case, it should only cost $6,000 a year for diabetes maintenance, but that cost could increase to an average of $95,000 for dermatology, mental health services, and potential surgery. Her savings would be multiplied over many more patients. Next. Our app will engage a wider audience in the digital space. Due to rising health concerns in younger generations, we aim to increase lifespan and well-being of individuals by providing them access to immediate resources. People can engage with groups in their area and find resources on topics like generational trauma, mental and physical health, and more. We have an opportunity to use this app for early detection in diseases and illnesses that impact BIPOC communities. Next. Our immediate next steps will be to confirm our hypothesis and proof of concept, validate Richmond, Virginia as a launch area, and focus more on future scalability. We would seek to partner with the payer that is most prevalent in that area. Next. Next. Thank you. Thank you all so much.
Thanks a lot. Lionel, do you have any questions? What about you, Dominic?
I don't have any.
Edgar?
I just want to be sure I understand. This is the development of an app which will give people have access to information about whatever they're interested in getting help or et cetera. So the project is basically developing an app.
It's actually developing a program and using the application to support the program that we're developing. And that program is embedded in the actual BIPOC communities. So that will build trust through their service level for healthcare.
So the app is only to support another program, the major program that you're developing with communities to help them get more access to what has to be done to solve some medical or physical or whatever access project problem.
Yes,
Correct.
yeah, we wanted that. Oh, sorry about that.
No, go ahead.
We wanted the app to be definitely support to the program to make it more accessible to people who may want to connect more in digital space, and also just to make it more accessible to people in general.
The trick there is going to be how you get people to use the app, I think.
And you're right. And that's the reason why we want to push partnering with community organizations and entities that are already there. That would be your synagogues, your AME churches, your Catholic churches, your Goodwills, YMCAs, Boys and Girls Clubs, and getting partnering with them and getting those organizations to encourage use of our app and seeing the value in knowing those communities.
Thank you very much.
One clarifying point. So this is really kind of like a three-legged stool with support for these people to actually use the app and then have that additional support from those community organizations that they trust for the program to be scoped out. Is that what I'm understanding, Victoria and Anissa?
Yeah, yes, it definitely is. It's definitely more of a support tool, and it allows people to access these resources immediately on their phone versus having to go into these physical spaces if they choose not to.
Thanks, Victoria. Thanks a lot for the
Thank you.
questions. Let's wait half a minute and then we can go into Hero One. Hero One, are you ready?
We are ready. Can you hear me?
Yes, I can. So I can start whenever you're ready.
Okay, go ahead. My name is Wendy Pelton, and I'm here to present Hero One, which is an app and web-based platform to connect Black teens with heroes. Next slide. I'd like to begin with a quote by John Lewis, who on the day before he died said that he urged all of us to answer the highest calling of our hearts and stand up for what we believe. Next slide. Our problem is two-faced. First of all, we recognize the suffering of Black teens through exposure to poverty and other unfortunate things. Also, the lack of coordination among people who want to mentor and those who want to get helped. Next slide. A little bit of background. Incarceration rates for Black Americans are higher than for any other racial group. Unfortunately, this leads to decreased educational opportunities, decreased job opportunities, increased homelessness, and many other poor health outcomes. We'd like to intervene before this is a problem. Next slide. Our app would match teens with mentors. It would be interactive, socially based app. It would allow point collection for participation in reaching certain milestones. Next slide, please. users would begin by taking an assessment, which would be a couple of questions based on whether they want to be a mentor or find a mentor. Then they would receive personalized feedback that would connect them with unique mentor support and possibly even connect them with medical professionals if needed or other community resources. Next slide. Again, our app is easily accessible. Users would begin by either downloading the app or accessing the web interface, which is integrative and easily accessible. Our focus is on prevention and on establishing mentor relationships. Next slide. For those with limited internet access, we proposed seeding a device, which would be downloading things in the presence of an internet connection, and then taking that device to a device that does not have internet connection to upload updates via an offline local connection. One of our users was from Brazil, and she had this idea based on what's being used there. Next slide. Here's an example of the app interface. I'd like to point out the points that can be accumulated in the center image and the opportunity for chats and feedback with mentors on the right image. Next slide. So why choose Hero One? Our main advantages are that our web-based device, or a web-based interface, and our app is conveniently accessible, is personalized, and feedback is timely. Next slide, please. We'd also like to recognize that we don't operate in a bubble, and we'd like to associate with educational institutions, government, health providers, and communities. Next slide. Our integration would be 3 phases. We begin by technical planning, and then phase 2 would be more
Your time
marketing
is
and
up.
advertising.
We will move on to Q&As with judges. Any questions from our judges? Dominique, Lionel, Edgar?
I'm glad that you mentioned that you won't be working in a silo and that you'll be working with the existing organizations. I think developing the pool of mentors that are qualified, I would say, is important. But also, I think it is important going after a population who normally, doesn't always reach out or know how to ask for help. And so I think your proposal is unique in that.
I think this is very ambitious and probably very desirable, but also very complicated to implement. But I might not clearly understand it. But if you're trying to get specific interaction with people who are well regarded, I don't know whether that's possible or not. You can be as an image, but to have a direct contact, I'm not so sure if that's what you're planning at all.
Right. Well, we would like that ideally. And one thing that we thought about was allowing mentors to have a limited time frame that they commit for so that they don't get overcommitted. It would encourage mentors to participate.
And on that question, those are influencers that we would like to endorse this wonderful, amazing undertaking, but there's going to be levels of influencers and levels of mentorship, and we will have training and onboarding. So we understand not all mentors are going to be Michael Jordan, but we'd like a few of those to get people excited by the possibility.
I guess that was more my question around feasibility for this particular population and maybe the lack of access, how that might have a different impact. So I'd like to see more information around the tiers of support or mentorship and, how you can have more contact for that group so that there's not abandonment issues should the limited interaction be very limited based on how it's scoped currently. But it's a good idea.
Okay, thanks a lot. Next up, and the final team is ComMai. It's Team F035.
Hello.
Perfect. We can hear you.
Hello. Okay. So may I start?
Let's wait 15 seconds and then we can start.
Okay.
I will let you know. Are you ready?
Yeah.
Perfect. I can start whenever you're ready.
Okay. I want to start right now. Okay. So greetings. Hope everyone is doing great. This is team F35, comma. Next slide, please. Records say approx 65% of population do not feel comfortable to speak up their problems due to lack of proper platforms. We believe that for any injustice, raising voice against the same is a crucial step towards problem solving. They feel helpless and poorly treated, and the reason why a 2015 report found that race is more strongly associated with mental difficulties contributing to stress, anxiety, and depression. So making this step impactful enough and help their voices reach concerned authorities is what we are dealing with. Because the moment like minded people come together is the moment when change really happens. Next slide, please. The solution that we came up with is an online platform which combines people with same motivation, which is racial injustice. Commie is an app that's a handy term for my community, a place where people are heard and impacted in an authorized manner, not just confined to the topic of injustice, but an interactive app that has a community-based feed, which will serve the purpose of awareness and instantly informing the concerned officials in the serious conditions, and also provides a healthy environment with a motive. Next slide, please. Sign up works with a zip code along with a SOS option for emergency situations. We can see on the right side that users are provided with options to register violent cases and inform concerned authorities. Anonymous button that helps people raise their voice even if they are scared, along with authentication of users at our end using existing NGO data. Next slide, please. Privacy is the greatest concern. So to overcome this issue, we have our own unique SSL certificate, dedicated servers, and to make sure users are not misusing authentication mark on verified users profile, instant proof capture in case of violent situations, involvement of existing NGOs. Next slide, please. Let's look at the business model. It will be invested by NGO and can be used by anyone, trustworthy as all information will be secured like a password, will be implemented using end-to-end user business plan. Next slide, please. On combining, let's take a look what makes us different. Fake IDs not allowed. Data is encrypted between the app and the user, so no in-between existences. Location cannot be tracked publicly, and it can be used in case of emergency. This was all. We are all connected to Wi-Fi, then why get disconnected from humanity? Let's hack racism. We thank MIT for this wonderful opportunity. Thank you. Next slide, please. Thank you.
Thanks a lot. Do we have any questions from our judges?
So if I understand, it would essentially be bringing folks from different backgrounds and communities together on similar issues. And I guess it would be, well, could you just expound on that? I just wanted to clarify.
Hello.
Hello.
I'd want Ravi to explain this. Hello.
Yes,
Yeah,
I was.
Yeah, actually our idea, main motive is to bring all the existing NGOs and along with the users, or let's say the person who get affected, to be make sure that they can raise their voice on a platform and can be led and justify socially.
And so, at first I thought it was just for, those that work in a specific space. So now I understand that it's actually a lot more broad and inclusive than I thought. And so that is a good thing. But I can imagine that essentially this could be a platform that is more so for collaboration and communication. And so could you just tell me, like, what's the selling point to how we, what are the action steps for bringing those folks together? Is it that they come up with their own ideas, that they are allowed the platform to connect?
Yeah, they can connect individually, and from a side of an NGO also, there is a verification that would be provided from the side of NGO if they want to communicate so, but they can communicate individually and come with their according ideas.
Perfect. Thanks a lot. I think with this, we conclude our final pitch presentations. So with judges, we will go into a private room and think about the winners. But I should say that I think for me and for the entire organizational team, everybody is a winner. So thanks a lot for coming. And we will inform you of the decision pretty soon. And and the Slack channel will be announced on Slack.